Yes, thank you very much for having the opportunity to be here. And I see that some people are leaving, and this has been a long day, but a very interesting day, I think. So I will talk about the implementation science and how to embed family-focused practices in services. So, first of all, why should we focus on implementation science? And what is implementation science? It is, one definition is that it's the scientific study of methods to promote the systematic uptake of clinical research findings and other evidence-based practices into routine practice. And implementation, it is a set of specified activities designed to put into practice an activity or program of known dimensions. There is an implementation gap between knowledge and performance. And what is adopted in the services is not used with fidelity and good outcomes for the consumers. And what is used with fidelity is not sustained for a useful period of time. It becomes a short-term project. And what is used with fidelity is not used in a scale sufficient to impact social problems. So instead of reaching thousands of families in need, we only reach a few. Fixen and Blaise have developed an active implementation framework. First of all, we need to know what the interventions we are going to implement and if they are effective and usable. What stages and what steps leads to the successful implementation, and what drivers and critical support are needed to make the change. What is the infrastructure? Who takes the responsibility for and helps to guide the change process? Have we established implementation teams? And how do the organization make use of improvement cycles to efficiently solve problems and to get better? The National Implementation Research Network, based at the University in Florida, has developed a list of core implementation components. First, we have the leadership driver, with both technical and adaptive support strategies. Next, we have the competency drivers, the staff recruitment and selection, and there is a need for the training of personnel in the new activity or program. And then we have the coaching and supervision, and research indicates that this coaching and supervision at the actual workplace are critical components. And in spite of new theory and training, we see that many practitioners find it very difficult to talk with children, and they hesitate to begin with child and family conversations. And it's very important to address this challenge in our training and supervision. And I thought it was very interesting to see that you have made a new module of supervision. Then we have the organization drivers. We need systems interventions. This is strategies to work with other systems. We don't work in silos. We can't work in silos. We need to work with other organizations and politicians to get support and cooperation, to get the public support, and to secure financial and human resources to support the work of the practitioners. We need to have facilitative administration. We also need a decision support data system to follow the progress of the work. And at the top of the pyramid, we need to do performance assessment to study whether the new program and guidelines are used with fidelity, and whether the work leads to improved outcomes for the children and families. Using diffusion strategies that just letting things happen, or dissemination strategies, like, for instance, having a conference, telling about the new things, that's not enough to make change. Implementation with expert implementation teams have success around 80% after 3 years, but the other types of dissemination can have up to 17 years of time and with only little success. Both implementation and leadership research highlight the importance of leadership in supporting innovations, in enforcing policies, in allocating resources and connecting the change efforts to the organizational culture and climate. And it's especially leaders who can inspire and motivate employees. They predict the implementation of innovative practices and gives a better innovative climate and gives also the more positive staff attitudes to adopt evidence-based practices. In 2010, we got a new legislation in Norway, which obliged the health professionals to strengthen their family-focused practice when a parent had a mental illness or substance use problems, or if they had a severe physical illness, for instance, like cancer. Darren Maybury, he describes family-focused practices as a continuum of practices needed to support the whole family unit, both the parent with an illness and the children. And it is not one practice, but it's several practices we need to do. We need to make the children visible. We need to have conversations with the parents. We need to have conversations with the children, give family support, and refer to preventive parent, child, and family support. So, in 2013 and 2014, we had a large multi-center study in Norway with 5 hospitals covering 34% of the Norwegian population, addiction, mental and physical illnesses. The main study was from stratified and randomly selected inpatient and outpatient units at 5 hospitals. But we also collected data from 16 other hospitals, 2 of them private, across all of Norway. Parents, children, and teachers were included in other parts of the large study, and I will talk more of the implementation part now. The main findings was that the changes in law were only partly implemented. There were differences between the hospitals, more challenges at the smallest hospitals. There were differences between the professions, more challenges for physicians and psychologists than for social workers and nurses. There was unclear anchoring and leadership, lack of resources, or they did not make use of the resources. There was a lack of quality improvement systems, a lack of communication and decision support data systems, and limited knowledge and skills for family-focused practice. And in this multi-center study, we were interested in whether the hospital used the implementation drivers that I told you about earlier. So I won't go into all the details here, but we found the significant differences between the hospitals on supervision, on decision support data systems, on leadership, and on the total implementation score. And our findings is in line with other research. A systematic review of implementation of evidence-based intervention to strengthen children and young people's mental health indicates that leadership, supervision, and performance assessment are particularly important in order to succeed in putting the work into system. We also looked at implementation drivers on the hospital size. And here is the data from all across Norway. And we saw that also here, the supervision, resources, leadership. That was the place that the small hospitals scored significantly lower than medium hospitals. We also studied the family-focused practice and differences between hospitals. We find that overall there was high scores on confidence, but they still needed training. But there was significant differences between the hospitals on workplace support, on knowledge and skills, and family support. There was lowest scores on family support and refers, which indicated moderate practice change. So according to the changes in law, dependent children should be registered in the parents' health record. And also here we found differences between the hospitals. The small hospitals scored lowest. There were differences between types of services, especially for the lowest for the physical illness at Hospital 4, where none of the patients they registered the children for the patients. And the highest total registration rates were from the two university hospitals that also scored highest on the implementation drivers. So, what is the most important predictors of family-focused practice? Is it the organization, the profession, the role as child responsible personnel? That was a new role that was given in Norway. We found that conversations with parents was associated with knowledge and skills and newly trained and younger health professionals. We found that conversations with children was associated only with co-worker support. Family support was associated with time for family work, specific training, co-worker support, type of profession. Social worker was a key predictor, but psychologists was very negative. They work more individually with families, individually with the patients. And gender, being a woman, and also the connectedness, the ability to assess how children are affected by parental illness. Referrals to support for parent, child, and family was associated with service available, having knowledge and skills, and being a social worker. So, did I? Okay. So what could we do with the situation, we thought? It was, you can see that it's a lot of different things and challenges in the hospitals. So one thing we could do is to make the children visible. And here is an example from a unit that made an improvement project over a 3 months period using a quality improvement board to visualize their work to improve their registration rates. We could improve the information, we could improve and welcome children and families to communicate our family-friendly policy in a better way. This could help the parents and children to ask for help, also in the situations where health professionals do not fulfill their duties. We also could work to improve the conversations with children and parents. And research indicates that raising awareness of the importance of having conversations with family and parents is one thing, but the research is clear. Conferences can raise the awareness. However, training in smaller groups, role play, practice, co-worker support, and supervision is needed to establish the new skills and to help change the health professionals' behavior. Our findings highlight the need to establish quality indicators and to tailor improvement strategies to the situation at the different types of services. Performance assessment and decision support data system is found to be important to support the implementation of the new practices. And creating a structure for implementation, ongoing implementation support strategies, and process evaluation with supportive feedback mechanisms and learning from experience are critical aspects of implementation, highlighted in a summary of different frameworks and models. I showed you earlier that we did the Children of Ill Parents study 4 years after the new legislation. And sadly, we were not able to do another follow-up study. But in 2019, we were able to study another changes in law that came the same year. And this study was These changes in law was about the support for family affected by domestic violence, and the municipality's support strategy and the crisis center that has built up in the municipalities to support them. And here we have combined the two studies and see that the crisis center, 10 years after the changes in law, they have much higher scores on the implementation drivers and than the Children of Ill Parents studies. And hopefully, if we have done the new study of the Children of Ill Parents, it would have been higher than after 4 years. But what is interesting is that also here it's some challenges with the leadership support. Implementation research is very clear, and they have found that a new policy in itself is not enough to change practice. And how can we plan for and install the infrastructure needed to support policy in practice? And how can we leverage the relationship among stakeholders to create an environment for change? And how can we use the improvement cycles to strengthen policy implementation? We need to work together, and we need to establish a co-creative capacity by deeply involving a range of key stakeholders across the scientific world, governance, and local practice boundaries to create the infrastructure and context that enables and sustains the use of evidence-based practice. And policy needs to enable the practices and practices need to inform the policy and needs to, we need a circle and we need to the improvement. And what we have seen in the, when I've been working with research on the crisis center, the child and the Directorate of Child and Families, they have had a more ongoing strategy and collected data, yearly data. And they have used the data and they have given research projects to the institutes to follow up, and they have made improvement plans. Whereas in the Directorate of Health, there has not been such, there has been a lack of some of these national strategies. It could have been better, in my opinion. Margaret Mead, she said that never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it's the only thing that ever has. So never doubt we can make it, though it takes a lot longer time than we think it should do. So, thank you.